Great. Well, welcome everyone. It's my tremendous pleasure to introduce a friend and colleague, Dr. Vanessa Meyer-Stevenson. Dr. Meyer-Stevenson received her BSc in chemistry and biology from Mount Allison University and went on to do a PhD in computational chemistry, as well as a doctor of medicine and her residency at Dalhousie University. She completed a fellowship in infectious disease at the University of Calgary and was a postdoctoral researcher at the U of C and the U of L when we hired her in the Division of Infectious Disease. And she joined us this year to take on the position of assistant professor. She's also an infectious disease physician at AHS. And so she really, I think, really fantastically bridges all the way from fundamental, basic science, all the way up to clinical practice. And I think we're going to hear a little bit about some of the outreach activities as well. She has an interest in chronic viral hepatitis and uses computational, biophysical, and molecular virology methods to explore various viral DNA, RNA, and host protein interactions. So welcome, Vanessa, to Global Health Rounds, and I'm super excited to have you here and to hear your talk today.
Thank you so much for that introduction. Yeah, thanks everyone for joining in and listening in on this topic. I feel very strongly about this, of course, from various different angles. When I submitted the title, I was just kind of initially just going for something a bit catchy, but then as I was putting this together, I was like, actually, you know what? This actually it suits it very well, because hepatitis B is a globally prevalent silent killer, and I'm going to tell you a bit about that today. But first, I do want to acknowledge that we are located on Treaty 6 territory, the traditional and unceded lands of First Nations and Métis people, on which we are learning and working today. So to highlight some of the stuff that I'll be talking about throughout this, I'm going to start big first, going with the global impacts of hepatitis B, discuss the role of the hepatitis B vaccine. Then I'm going to switch gears, go quite small, and talk about the virus itself, some of the challenges around the virus, and some of the unique approaches that researchers are taking, including throwing in a few slides of my own work, and trying to keep everybody on the same page, that I don't dive too far into the basic science. But I also will conclude with one thing to help that you can do to also help contribute to the awareness. So starting with the global impacts of hepatitis B. So the World Health Organization estimates that over 296 million people worldwide are chronically infected with hepatitis B. And the virus disproportionately affects people, those in sub-Saharan Africa and Southeast Asia. In Canada, while our numbers aren't exact, we have ranges around estimates of around 250 to 450,000 Canadians, which is not minor either. The fact that we have limited Canadian data is challenging for making policies and moves forward on this. The hepatitis B is a notifiable disease in Canada, and in 2019 we actually had almost 5,000 cases reported. Again, we weren't able to really clarify whether or not those were all acute or chronic or what the proportions were. There was a study in BC that looked at the prevalence of hepatitis B over a 30-year period, and they had 46,000 cases. 96% of those were chronic, and again, largely in the Asian population and those that were more socioeconomically deprived. And then just jumping down to the bottom here, there's a Canadian health measure survey that looked at whether or not people actually knew about their diagnosis from the screening set that they did in these studies, and about 50% were even unaware that they had it in the first place. And so part of the survey that was done ended up having to diagnose or disclose a lot of these new infections. So we don't have a lot of data, first off, and the range and the rates across Canada varies, and this can make it difficult to generalize for a lot of these things going forward. Other thing that varies across Canada are the hepatitis genotypes, and there's a lot of variation from province to province, and even within our own province. So here in Alberta, we have very different profiles in both Edmonton and Calgary, as if we needed more evidence to show that our cities are very different places. The hepatitis B genotypes are also very different. But the lightheartedness aside, the reason the genotype information is also important because genotypes can often link to risk for severe disease and relations to how someone responds to therapy, et cetera. So knowing the genotypes are actually one part of that approach to knowing what your population needs and going forward. Now, the diverse genotypes that we have across Canada are largely related to the diverse populations that we have, immigrant populations, and sort of where the home country of origin for many of our immigrants. And you can see here that the different genotypes have this very specific geographic distribution in some areas, which makes it quite interesting for being able to backtrace where these different viruses may have come from. Now, those with chronic hepatitis B are at increased risk of complications from the virus, including cirrhosis and hepatocellular carcinoma. And this is the preamble and kind of all of this leading to what makes it a silent killer. So the World Health Organization estimates that over 820,000 deaths occur annually from hepatitis B, and this is largely from cirrhosis and hepatocellular carcinoma. And data from North America alone on cancer rates show that while lung and breast and colon cancer are decreasing over these past years, liver cancer deaths actually continue to increase. So raising that as a specific flag for a lot of this. So just to give a bit of a sense of the natural history of the disease. So you can have a healthy but hepatitis B infected, HBV infected liver that then goes on to have inflammation, and inflammation over time can lead to scarring or fibrosis, and that fibrosis can eventually lead to cirrhosis if it's untreated or unmanaged. Cirrhosis in and of itself has the potential to have complications around decompensation, and so 15 to 20% of people over the course of 5 years after they've been diagnosed with cirrhosis will have decompensated liver disease, which has a whole pile of complications associated with that. But also after a diagnosis of cirrhosis, there is also a 15 to 20% chance of hepatocellular carcinoma. Now, unlike hepatitis C virus, where this similarly occurs in that sort of linear fashion, inflammation, fibrosis, cirrhosis, cancer, hepatitis B also has this additional route to causing cancer, and it is able to insert into the genome. And if it inserts into places where there were oncogenes or that sort of thing, you can actually develop cancer directly without having any of these other stages, which makes it even more concerning for being able to follow it and check it and catch it. And so this occurs at a rate of 1 to 3% over the course of 5 years for someone with a healthy liver. The rates of progression and the complications around this are all do have some link to both the clinical and the virologic factors. So the older you are, if you're of male gender, other concomitant conditions, viral factors such as the genotype, viral loads, and different co-infections could all impact the rate at which you progress through these different stages. As well, treatment, monitoring, and interventions can also help slow the progression, reverse some of this in some cases. Overall, though, if you do develop complications such as cirrhosis or HCC, the annual death rate for someone with chronic hepatitis B turns out to be 20 to 50%. When we look at the global prevalence of liver cancer, specifically across the globe, this has very different rates and implications. While I mentioned that, with treatment and interventions, we can change and we can reverse this. Well, in many places, that's not the case, and that it isn't an option. So in low-income countries and low-income settings, many people will die of liver cancer within months of their diagnosis. And in high-income countries, such as North America, have the ability to do some of these changes and can extend things from several months to a few years. So again, this is all to kind of highlight the impact of this globally and address kind of why this virus in itself is such a silent killer. So first off, in the clinical sense, so it's silent clinically. The virus itself can actually affect someone for decades without showing any disease or any outward signs of infection. And it predominantly infects, or more efficiently affects, young populations, so neonates, children, young adults, and to be able to create a chronic infection. It also spreads asymptomatically. So mother-to-child transmission, or MTCT, is the most common mode of transmission worldwide for hepatitis B. So this virus has figured it out. It knows how to work with us and use us for its purposes and its propagation. This virus has been around for centuries, so it's able to infect people young before their childbearing age, pass efficiently during childbirth, and not kill its host, so that it can keep propagating. And when I say that it has been around for centuries, it quite literally has been around for centuries. There is hepatitis B was identified, exhumed mummy in 16th century Italy, in this area, and they were able to find it in the tissues of this child. And if you were wondering, it was a genotype D, which continues to be the genotype prevalent in that area today. So why is it also so silent? It's also silent from a social sense. And so worldwide, the predominance of hepatitis B is in these lower socioeconomic status countries and populations. And in Canada, it does largely affect our immigrant population, who are known to have less of a voice than non-immigrant populations. There's also still the stigma that's associated and linked to bloodborne illnesses as the mode of transmission. It's also silent because of lack of awareness. And this is where I bring up some of the myths and misconceptions of hepatitis B, including things that's around the vaccine. So we have a vaccine and it's highly effective, therefore it's not an issue, especially not in Canada. Well, yes to this first part, yes to this, but hold up, let's address this here with the relation to this being an issue and in Canada. So this is where I'm going to get into discussing the role of that hepatitis B vaccine. So the risk of developing chronic hepatitis B after an exposure is age-related. So the younger you are, the greater the chance of you developing a chronic infection. So in neonates, so around the time of birth, children who are exposed to hepatitis B have an over 90% chance of developing chronic infection with exposure to the virus. Contrast this to adults, where you have less than a 5% chance of developing a chronic infection. This is even without a vaccine, you have less than a 5% chance of developing chronic infection with exposure. These facts in and of themselves are evidence enough why we should be introducing birth dose vaccinations and universal birth dose vaccinations. This is actually a recommendation of the World Health Organization for this. So how effective are vaccines? If you give a birth dose vaccination to a woman who has actively replicating virus, and I'm using this term antigen positive as that marker, you can reduce the risk of transmission to her baby from 90% down to 21%. If the person is not actively replicating and has lower viral loads, this can be reduced from 30 down to 26. In addition, if we also add in hepatitis B immunoglobulin, which is another standard of care for babies born to hepatitis B positive moms, you can further reduce this to 6 and 1% respectively. So we have a vaccine that is so effective that when given at birth, you can reduce the risk of transmission to that child from 90% down to 6%. These numbers are phenomenal, and also bodes for why we should be having universal birth dose vaccination. So how are we doing here in Canada? How are we doing in Alberta first? So in Alberta, we actually don't vaccinate children until they're in grade 6, or at least before 2018. So that's it, getting into the junior high cohorts. Yeah, in March of 2018, we changed our vaccine program in children to begin at the 2-month mark. So when moms are coming in for their first postnatal visit, 2, 4, and 6 months. So we're getting better, but we're still not getting those getting the children and the newborns. So how are we doing across Canada? Well, there are still several provinces, 5 provinces that are still at the grade 6 vaccination for hepatitis B. There's only 1 province and 2 territories that actually meets the WHO guidelines of birth dose vaccination. That's New Brunswick, Nunavut, and Northwest Territories. And so you may counter this argument and say, in Canada, well, our rates aren't so high as in other countries, so it's less of an issue than in other places. And you would be right. I would say, yes, it is less of an issue. Then I would show you this data. And so this slide is actually courtesy of Dr. Carla Coughlin, and she gave this slide as part of the presentation at the International Hepatitis B meeting recently where she described the myths of hepatitis B in Canada. And this is presenting data from a study in Ontario recently published looking at the rates and the prevalence of hepatitis B among children. And just kind of waving my mouse over this section on foreign-born, yes, there are many children who are born and come to Canada and they have hepatitis B. So those people we could not have intervened on prior. But we have this cohort here wrapped around this box with this red box of 139 children who were born in Canada that we missed the opportunity to protect them from getting hepatitis B. So that's 139 children born on our soil. We had the ability to prevent their infection and we didn't. And this is one of the downfalls of this not having a birth dose, universal birth dose program. And it's a shame that we have had those numbers. And again, this is just for Ontario. This is one province. We don't know what the data is for the rest of the country. Because of the prompting from that study, Dr. Coffin and all of the members of the Canadian Hepatitis B Network, of which I'm also a member, wrote a letter to the Minister of Health and NACI, so the National Association for Committee for Immunization, and we said, you know what, we need to advocate, we need to instigate birth dose vaccination across Canada. We shouldn't be having these things happen. And essentially, the letter that came back said, well, vaccines are dealt with by the provinces, and things have been working over the past 2 decades, and we'll just leave it at that. Provinces can deal with it. So not only is misconceptions and myths about hepatitis B an issue, but potentially also complacency on some of these fronts. So again, these misconceptions playing a big role. The other one is that perhaps we're not as aware as it, but yes, okay, so but hepatitis B is chronic and there's no cure. Yes, that's true. However, doesn't mean we can't do anything. There's still lots that we can do. And there's a lot of great research happening. And this is where I'm going to start diving into some of the challenges, first off, around hepatitis B and its chronicity, and then some of these unique approaches that researchers are taking, hopefully provide that sense of hope for both you to be able to pass on to patients, and when you talk about screening or that sort of thing, to just say, just to change your perspective on that it's not just a doom and gloom scenario. So let's, we're going really small now. We're going right down to the size of the virus. So hepatitis B virus itself is an enveloped virus. It measures only about 42 nanometers. And if you're curious, the coronavirus is about 120 nanometers. So it's 3 times smaller in that size. It has a partially double-stranded DNA genome, which is 3.2 kilobases of DNA. Again, coronavirus is 10 times that. It is 32 kilobases of DNA. So this is a very small virus, one of the smallest that affects humans that is even known. And there are multiple serotypes and genotypes from A to H, and I alluded to that with my global prevalence of genotype slide. So the virus itself is packaged in this small, in this capsid of hepatitis B core antigen, and I'm highlighting that mainly because I know some of you are clinicians on the line, and you order anti-core antibodies sometimes, and so that's where that one comes from. The membrane is composed of surface antigen embedded in membrane material taken from the host. And this is shown here in this electron micrograph. The reason I really like this electron micrograph is because it shows all of this other stuff. This other stuff is actually the subviral particles. So when the virus is being produced, it also produces all kinds of this other subviral particles of the surface antigen in these little empty packets and these empty things. So it's just producing, spitting out all kinds of this surface antigen. And what this actually does is it effectively acts as a decoy for the immune system. So you have lots of surface antigen floating around in your blood, and your immune system is fighting and trying to deal with all of this, and it doesn't know if there's virus inside or if it's not, and it's trying to attack all of this. And this is actually one of the reasons that hepatitis B leads to the immune exhaustion and the T cell exhaustion that's associated with chronic hepatitis B. And so just to kind of give a snapshot of the life cycle and current drugs for hepatitis B, I'm going to show you this figure here. So this, if you can follow where my mouse is right now, so just the virus enters in through a receptor on the hepatocytes, the NTCP receptor, which is actually a bile salt receptor. It's only discovered in in 2012, so actually fairly recently. So it gets in, it makes its way into the nucleus, and once it's in the nucleus, this partially double-stranded DNA gets converted to fully double-stranded DNA, or cccDNA, which is covalently closed circular DNA. And it does this through different DNA repair mechanisms that our cells already have. And when it does, once it's in this double-stranded DNA form, it's actually very stable. It's supercoiled, it's wrapped around histones, and it actually looks just like our regular DNA, and it's hidden away in there so that the immune system is not going to see it. And it's this form of the virus that makes it chronic, because it's this form that produces all of those transcripts that are needed to make the different proteins, to make the pregenomic RNA that then gets packaged and sent out of the cell to infect other cells. Fighting against these, against the virus, are a very limited number of drugs. We have essentially two approaches to treatment at present that are approved. Are interferons. So interferons are essentially stimulators. They actually also have antiviral effects, but they stimulate the immune system to try to go after it and recognize it and attack these cells. And then we also have a group of drugs called the nucleoside or nucleotide analogs. And what these are is these are drugs that affect the DNA polymerase, or the reverse transcription step in the virus. So after the capsid is formed, this enzyme completes the site of the part of the pregenomic RNA that gets converted to the other form of the RNA that's needed to go infect a new cell. We currently have 6 of these nucleoside analogs available and approved for treatment. But the first one, and the one that started it all, was of course lamivudine, and this has a homegrown link. Of course, this was produced largely from the perseverance and work and team put together by Dr. Lauren Terrell, founder of the Li Ka-shing Institute of Virology here in Edmonton, and ongoing active colleague with our Department of MMI and researcher. He, with the team, developed this drug, and he actually predicted that, you know what, we'll have this for a while, but resistance will develop. And just as he said, certainly within years, we were already noticing that there was some resistance developing, and lamivudine is actually no longer used as one of the first-line treatments for these drugs, for this condition. We currently have about 3 right now, 2 depending on how you count the prodrug, that are approved for use in hepatitis B. But the thing with this, again, though, is it is very good at lowering the loads of the DNA in the bloodstream, and lowering those loads, which also effectively lowers some of the inflammation that the liver is seeing and all of that, which is a good thing overall, really important to do. The thing that it doesn't do is it doesn't treat this cccDNA. It actually, and the problem with that is that this is now able to still continue on spitting out the virus, and as soon as you drop that drug, the virus is able to replicate and start all up again. And so one of the approaches for cure, and one of the strategies for cure, is actually more of a functional cure. So when we talk about that hepatitis B goal, we talk about reaching functional cure, which is actually surface antigen loss. So while we have all of these little things being spit out into our bloodstream, distracting our immune system and tiring it out, we have, if we are able to lower that, remove that, and have a loss of that antigen, we actually have evidence to show that actually leads to a functional remission and improved long-term outcomes. And getting there, though, is its own challenge. However, some patients can do this spontaneously, and spontaneous loss of hepatitis B surface antigen, or seroconversion, in which you develop the antibody to that. So this is something you would develop in a vaccine, for example, actually occurs at a rate of 0.5 to 0.8% a year. And so overall, we say we have about 5 to 7% of patients will spontaneously seroconvert and clear that virus. First off, clear the protein from their bloodstream. Doesn't mean that the virus is completely gone. It is still hiding away in the liver in that cccDNA form, but the outcome of this is so much greater, and the improved rates of all of those other chronic outcomes is so much greater that we actually even stop doing screening ultrasounds. there's been a lot of research done as well saying, okay, what if we can suppress the virus long enough? Can we kind of induce this as spontaneous, or can we induce this clearance and whatnot? And even with prolonged treatment with those nucleotide analogs and combination therapy, these don't actually change the outcomes beyond what would otherwise occur spontaneously. And so there's still a lot we don't know about the virus and about trying to tackle this. So just to kind of give a snapshot of some of these newer approaches, I'm just checking my time to see how much I can ramble. So there are all kinds of new approaches and creative ways of tackling this, including things such as therapeutic vaccinations. So actually where you stimulate the immune system to see the virus again, or maybe to see the virus in a different way, to have it attack the cells, to shut down transcription through silencing RNAs, so small interfering RNAs, through different epigenetic modulators. So as I mentioned, this cccDNA is actually wrapped around histones. And so it's also bound to the same rules of epigenetics as our host genome. And then different things to impact different components of the life cycle. But then I want us to highlight a couple of these types of approaches in particular. And those include the NAPs, the nucleic acid polymers, entry inhibitors, and this CRISPR-Cas9 gene editing system. And then, of course, I'm going to talk very briefly about my own work on quadriplexes and highlight this in 2 slides or less for each of these. So bear with me, but I get really excited about when I see some of these new approaches, because it's really an exciting time for patients to be able to explain that we have a lot of things on the horizon. And one of those first methods, okay, so the nucleic acid polymers. So remember how I said surface antigen, and the spewing out of surface antigen is one of the things that leads to all of the complications and immune exhaustion. Well, nucleic acid polymers are actually, so they're a modified oligomer of a modified string of nucleic acids that can actually prevent the formation of some of those subviral particles and prevents the release of those into the bloodstream. So effectively, instead of having all of those decoy little subviral particles of the surface antigen being spewed out into the bloodstream, NAPs are actually able to block that and effectively clear that from the blood. So this is sort of an artificial way of lowering it from the blood, but then that gives the body a chance to attack those liver cells and clear that. And so we have 2 different companies that are currently working on those. And this one actually is in Canada and in Montreal. They're the furthest along. So these are in phase 2 clinical trials. And while I have no stock in any of these, I just want to highlight some of this because of the excitement of the outcomes of the potential of this. And this is one of their lead compounds where they showed, this is the treatment with tenofovir and interferons, and then tenofovir interferon plus their drug. So the blue versus the orange. And if we look at, this is the serum DNA. So both are able to lower the DNA. It's likely all related to the tenofovir and interferon combination. Then when we look at this here, so this is for surface antigen. So surface antigen with the tenofovir interferon combination, essentially stable, it's not doing a thing. When you add in these NAPs, you actually grossly lower that surface antigen, and this can lead to seroconversion in many cases. So seroconversion, so you develop antibody against surface antigen. So it gives the body a chance to catch up and to give it a chance to overcome some of that stimulation. The other thing that this also shows is this is serum ALT. So we measure liver enzymes with any complications of the liver. So this refers to liver inflammation. So this, while this is elevated, and this is something that we'll have to be cautious about, this actually implies that the liver is reacting to what's happening inside and it's trying to clear that virus. And so time will tell on these on this front, and as we do more studies, but it's just an exciting approach because it's something new, something that we haven't had before that's been able to lower and so drastically those surface antigen. Another one I wanted to highlight are the entry inhibitors. So you might think, okay, well, if something is already chronic, what's an entry inhibitor going to do? And I am partly highlighting this because of its potential for hepatitis D. What makes this exciting is that this is a potential cure for hepatitis D. And I'm bringing this up because this is very new. These slides are actually from the International Hep B meeting that just happened in September. But an entry inhibitor. So Dr. Stefan Urban was doing work on figuring out what the part of that surface protein is necessary for entry into the cell. And he ended up making a mimetic of that shown here that can then block entry of hepatitis B. So you can actually block both hepatitis B and hepatitis D. Now, hepatitis D, I didn't actually introduce this very well, but hepatitis D is actually sort of a defective virus, and it needs hepatitis B and it needs its surface proteins in order to actually complete its cycle. So it's not even a full virus. It's a viroid. It's missing part of its. It doesn't make the surface proteins to be able to do its own complete its own cycle. So if you can lower the surface antigen from B, you actually have a chance of preventing hepatitis D from reaccumulating and getting back in. So this the drug that he's developed is currently approved for use in Europe. It's currently in phase 3 trials there and post-marketing trials. In the US, it's in phase 3 for hepatitis D and phase 1 and 2 for hepatitis B. And essentially, it's able to show that we can lower those the level of the hepatitis D RNA. And then again, what makes this exciting is for the first time we actually have a treatment that's not interferon. So interferon has so many side effects and all this fun. But this is on the horizon for this. So an exciting new option for people with concomitant co-infection with D and B. And here I just show one of the tables here that highlights the seroconversion, the loss of surface antigen in this study, and the production of the antibody against the surface, which is again first time for these sorts of therapies. And then the third of these new strategies I wanted to highlight was that of the CRISPR-Cas9 gene editing strategy. Now, some of you may be familiar with this already, but this was actually a technique that was discovered in bacteria and then adapted and for use in other systems. And its discovery and adaptation is attributed to these phenomenal researchers, Dr. Jennifer Doudna and Dr. Emmanuel Charpentier, who were both awarded the Nobel Prize for Chemistry in 2020. And their work is now it's used in labs around the world. There's so much of the application of their technology and this discovery going forward, which makes it no surprise that it's been extended to the potential use in hepatitis B. So for hepatitis B, a couple of the therapies that are currently in preclinical trials are these different options for being able to cut and edit the cccDNA. So if you can make something specific enough, bind to the cccDNA, you can actually effectively either mutate it, render it inactive, or you can break it open and cause it to be degraded by the normal cellular mechanisms and whatnot. And so that in and of itself has a fantastic potential going forward with this. There's still a lot of issues with that, of course. Sometimes the editing can be non-specific and there's some challenges around that, but just the fact that we are in a stage where we have the potential to do some of this work makes it an exciting time for potential of hepatitis B cure in some of these patients. Moving this into the mouse model, so having this similar CRISPR-Cas9 editing, here I want to highlight some local studies again, or some local links to the studies. So Dr. Connie Lee was a PhD student in Dr. Monterell's lab. She's currently in medical school here at the University of Alberta, but she took part in the studies around doing the CRISPR-Cas9 work in the mice, and the mice that were used for these humanized mice that are actually also linked here in Alberta. So those humanized mouse model, or the Phoenix Bio mouse, are a product of KMT Hepatech Phoenix Bio, which was developed by Dr. Lauren Terrell. Sorry, I'm gonna say this in order, but Dr. Norman Kniedemann, that's the K, Dr. David Mercer, that's the M, and Dr. Lauren Terrell, the T of KMT Biotech. This was developed in 2021, and the company has since been bought up by Phoenix Bio. These cells and the mouse model are actually widely used by hepatitis B researchers around the world and are becoming the new standard for having a humanized mouse model from a lot of that front. That brings me to my last few slides. How am I doing on time? Excellent. My approach. So I am going after that cccDNA. So my thinking around this is that if you're going to do any of these therapies, you need to go after that cccDNA, and you need to do it selectively. It can't be, it can't have off-target effects, so it needs to be very selective. And my approach to this was taking a closer look at it. So you have a form of the virus that's really tightly bound, very stable, supercoiled, wrapped around histones. Everything else looks just like our own DNA. So how are we going to actually tackle it? Well, it doesn't always exist in that tightly wound form, because for it to undergo transcription, it needs to open up and it needs to expose certain regions of its DNA to be able to recruit host proteins. And it does that at promoter regions. And in hepatitis B, there are 4 promoter regions. There are 4 open reading frames that are highlighted here with these green arrows. And in this region here, in the pre-core promoter region, is a segment of DNA that is highly guanosine rich. So there are lots of Gs in that DNA. Why that's interesting is that highly G-rich regions are actually able to form what's called quadruplex. So essentially what this is a fold of DNA stabilized by these different bonds that allow this 3-dimensional structure of stacked guanosines on top of one another. And effectively, this is a knot of DNA. And these knots of DNA have been found throughout our human genome, throughout many species, and they are highly prevalent in promoter regions, in telomeres, in regions of important class, important class switch, in exons. So in regions of high importance to the DNA and DNA stability. It has been shown to be able to slow the production of the virus of a transcript down. So if you have a knot in the DNA, it needs to be unwound, or you can then transcribe that. So it has this epigenetic effect. And it also has this effect as a bit of an anchor. So it's able to recruit viruses, or say, focus on the virus, it's able to recruit host protein to the site, or recruits protein to the site to enable the transcription, so transcription factors. And an older study in 2001 showed that if you mutate one of these nucleic acids, you lose the production of the transcript, and they went on to just show kind of the different mutational studies. But then when we kind of stepped in to have a look at this, we were like, okay, well, you know what, if you mutate that, you are actually likely able to destroy that quadruplex and just from that one mutation. And so when we looked at the study, we actually found that when we looked at this through different computational and biophysical methods, that this actually does form a quadruplex, this little 3-dimensional knot of DNA. And when you change one of those nucleic acids, you actually end up unwinding that quadruplex. And this is what we hypothesized was kind of the basis for going forward with this. So during my postdoctoral fellowship, I went on to do further work around this to prove that these different mutations, when you make them, can modify that region, and it acts differently from biophysical methods. And when you put it into cell culture models, it actually acts differently there, ultimately leading to different rates of the downstream production of those transcripts and the protein that comes from that. So this was part of the basis of some of my work there that I'm bringing forward. What makes this also interesting is that this is a pan-genotypic approach. By that I mean, remember all the genotypes that I had mentioned that hepatitis B has? Well, unique to hepatitis B research is this database of reference genomes from around the world. So we have over 70,000 reference genomes that are deposited there all across the globe from samples that have been isolated from patients. What makes that important is that those samples then represent viruses and types of viruses that have been replication competent. And therefore, so if they get put into the database, these viruses are the ones that are able to kind of keep propagating. And if we look at this region here that I was highlighting in the pre-core promoter, this highly G-rich region is actually highly conserved across all genotypes, and which is really reassuring for any sort of approach in therapy targeting this. You might also, if you've got a keen eye, you might say, hey, what's happening with genotype G? That's a bit of the oddball out. Well, it's actually the oddball out clinically as well. Genotype G is only found in combination with either genotype A, and there's one study where it was isolated in a patient that also had genotype H. So genotype G is actually another sort of enigma on that front, but save that for another day. But overall, highly G-rich region in the pre-core promoter across all kinds of, across all of our genotypes. And again, conserved for centuries. So that mummified 16th century child mummy that was from Italy, also that region 100% conserved. So this region has not modified or has not, despite the potential for it to change and mutate over time, this region in particular has not modified, which says something to the effect of the importance of this in the virus's propagation. So my strategy is looking at this from a computational approach, incorporating various studies of biophysics and molecular virology to try to figure out the way to bind to this little quadruplex X, that little knot of DNA, bind to it selectively, that we can actually target it with drug therapies to be able to move forward with potential for treatment with that. And so to really give that summary for that therapeutics section, that sort of, this is what's on the horizon, these are the potentials that are out there. Just want to highlight that, yes, there's a challenge, but there's a lot of motivation and drug company interest is out there. And in particular, we did it for hepatitis C. Why not for hepatitis B? I've also even highlighted that we're nearly doing it as well for hepatitis D. So just stand by on that one. But that there are a lot of new therapies and trials on the horizon, a lot of networks internationally and locally or nationally that are involved in all of this, which is fantastic news for patients. And then I wanted to add in, but what if you didn't know you had hepatitis B? How would you even take advantage of any of these therapies or get initiated into these sorts of things? And this is where it comes down to my my fourth objective, the name one thing that you can do to help contribute to hepatitis B awareness. And this is where I make a call out to my clinical colleagues here on this one. So this is where I say, consider performing once a lifetime screening in all your patients. And by screening, I mean, this is screening for hepatitis B surface antigen. And if you remember, that's the antigen, that's the last thing to clear. That's the one that's the highest amount and the easiest to pick up in the bloodstream from all of these different testing. And so I encourage you to consider just throwing in a surface antigen test whenever you think of doing your screening for HIV. And this approach, this once a lifetime screening, is actually endorsed by the Canadian Hepatitis B Network, along with our birth dose vaccination. So that's not gone by the wayside yet. It's still strongly being advocated. But of those two things, but this is something that you can do in your clinical practice to help contribute to that. If patients are aware, then you can get them into programs and whatnot. The other thing is that you might think, okay, well, why am I screening my 65-year-old patients in for cardiac problems? Well, no person is an island. We're all connected, and that 65-year-old and with cardiac troubles may actually have a daughter that's pregnant or considering pregnancy. And sometimes a lot of our hepatitis B cases are picked up from screening around from a new case, so of a family member who gets diagnosed, and then sort of ring screening from that front. So not a completely benign sort of intervention as a potential for increasing that awareness. And so to summarize, my last slide here, chronic hepatitis B remains a concern worldwide. There is an effective and preventative vaccine, and this is best given at birth, and it is a recommendation of the World Health Organization. We still have a ways to go in Canada. Treating hepatitis B will require a multi-pronged approach, but there are lots of things on the horizon, and there's promising research being done. So there's a lot of positives to be able to give people going forward. And I do highly recommend that you consider screening your patients with hepatitis B surface antigen. Again, all contributing to the whole concept of being aware of hepatitis B and making sure that it doesn't remain a silent virus, because we can do something about it. And I'll end there with some extra time for